Top of the morning, Dan and Amy. We experienced this last summer during the rioting in America's cities that public health professionals would say to questions about, well, wait a second, if masks are so important, if they're such a prophylactic, so preventative against COVID spread, then shouldn't there be criticism? Shouldn't Black Lives Matter protesters and others who are creating unrest in the streets be admonished for not social distancing and not wearing masks? And the public health professionals would tell us, well, there are competing issues here. There's the public health crisis in the form of COVID-19, and then there's the public health crisis called racism. And so if your cause is righteous enough, then you can dispense with the safety protocols, was clearly the implication. That was just, random public health academics. Now we have the CDC director essentially adopting the same posture, that racism is a public health concern that should fall under the purview of the CDC to make recommendations. Well, our friend Dr. Joel Zinberg disagrees that this should fall under the purview of the CDC. Dr. Joel Zinberg is a senior fellow at the Combative Enterprise Institute in D.C. He's also an associate clinical professor of surgery at the Mount Sinai Hospital in New York. He joins us now. Dr. Zinberg, thanks for being with us. Appreciate it.
Thank you for having me.
So you're not on board with Rochelle Walensky and her comments on racism as a public health concern that someone like her, a medical doctor and the head of the CDC, should be commenting upon or should be thinking about spending CDC resources to promulgate guidelines and recommendations?
Right. Basically for two reasons. The evidence she cites to support this is the claim that blacks are disproportionately affected by COVID. And while that was once true, it no longer seems to be as true as it once was. So blacks are slightly worse off in terms of deaths compared to whites, but not really anymore. They're pretty close with the gross figures. And then when you weight it for where people live and where COVID has hit, you find that blacks are really no worse off than whites. So number one, the evidence isn't there to support the claim. And number two, the CDC's primary mission is supposed to be to stop communicable diseases. And here we are in the midst of the worst pandemic in 100 years, and she's talking about moving the CDC to investigate racism in medicine. I think it's a crazy time for her to be promoting this as a goal of the CDC when they have a pandemic to fight.
And the Center CDC started in, 1946 as a way to prevent the spread of malaria, and it's morphed into domestic violence, gun control, and what else?
Well, vaping and all kinds of things that are really pretty tangential and far afield from what their primary goal is. They are not the sole governmental health organization. You have the National Institutes of Health, you have the FDA, you have all kinds of organizations, and then you have private entities too. There are a whole host of entities that could be investigating racism in healthcare, and not the CDC in the middle of a pandemic.
And it's interesting you raised the specter of what was discussed a lot in the first few months since after the outbreak in the spring to the summer of last year, that blacks in particular, but black and brown people versus whites, which is always the construct, they were suffering more. And this was something that was talked about endlessly in those spring and summer months last year. And it actually has sort of disappeared from the conversation. And, I hadn't really thought about it. I'm glad you did the analysis. But, so things level off, because this is a long game with respect to a response to the virus. And so what they were saying last year, they just sort of quietly walk away from, which is also telling, rather than trumpeting that fact. Hey, we thought this was happening, but it turns out right now that what we thought initially, like on so many measures, is not really the case. And so I want to walk that back in a little bit.
Right. I mean, it's now taken as a given that there's a disproportionate effect. I mean, the thing that ought to raise your antenna is when you hear a public health official say something with these words, "We know that," and as soon as they say that, you should be very aware that no, they probably don't really know that, but they are making a politically correct assumption, and that's what's gone on here. As COVID has spread from the initial places it hit, which were primarily large urban areas and in the Northeast, as it spread around the country, it spread to areas where whites formed a bigger percentage of the population and blacks formed a lower percentage of the population. So as time went on, more whites were affected, and as a percentage, fewer blacks were affected. So now it's sort of evened out. I mean, blacks are still a little higher, a percentage of the deaths, and that's for a few reasons. They have more comorbidities, more illnesses. They are in employment that doesn't allow them to stay home as compared to whites. But it's almost equalized, and no one wants to talk about that. They just say, we know that there is disproportionate impact.
It seems like this is one of the ways in which science has been a casualty of COVID-19. The willful dismissal of the idea that we live in a world of trade-offs is one of these things. The idea that something that's novel, like a novel coronavirus, your understanding is going to evolve over time as you experience it, plus research it to try and get a handle on it, rather than treating this as static. You know, we come to this initial conclusion, and we're sticking to this conclusion regardless of what the science and data tell us.
Right. No, I mean, to me, the disturbing thing is that science is being recruited to fulfill a political narrative, and it should not be, particularly at this moment in time when accurate science and accurate communication with the public is so important.
How do you react to some of the news out over the last few days that states, including Michigan and Oregon, are contemplating extending at least some of their COVID-19 restrictions in perpetuity? I mean, there's no particular end date. They're not looking to get out. They're looking to make the restrictions they imposed part of the new normal.
Well, the problem is, as you pointed out, the science is sort of being ignored. There's very little evidence that the lockdowns have a tremendous impact, and in part because the evidence that's accumulated doesn't take account of the fact that people voluntarily take actions on their own to avoid risks. So every kind of diminution of number of cases and hospitalizations and deaths is attributed to lockdowns, when in fact they could be in large part attributed to people's voluntary actions. And these, in addition, there have been multiple studies indicating that some of the less restrictive forms of mitigation measures are equally or more effective than the really severe lockdown types of measures that have been taken in some countries and unfortunately in some states. So, you know, the fact is what the states ought to be pushing is vaccinations and proven mitigation measures, and not pushing these very strict and stringent mitigation measures.
Well, how do you feel about, mandatory vaccinations? I mean, here we have again, today DePaul here in Chicago and Columbia College, they both said you have to, if you're going to live in the dorms, you have got to be vaccinated or you're sorry.
Well, look, vaccination has been allowed to be mandatory in certain circumstances for well over 100 years here. Kids in every state are required to be vaccinated. I'm talking about grade school kids, are required to be vaccinated for childhood diseases. So it's not as if this is something out of the blue. And many medical facilities require their staff to be vaccinated, for example, against influenza. So you don't need mandatory vaccination on a population-wide level, but you certainly could consider a mandatory vaccination in certain settings, like healthcare facilities and nursing homes, where the vulnerable population happen to live and congregate. Now, I'm not suggesting you need to do that. You need to see how how many people have voluntarily been vaccinated, and is that adequate? And you can do various things to try to incentivize people to be vaccinated. But in some settings, it might be needed.
There is still this pounding away on recalcitrant Americans when it comes to getting the vaccine, suggesting that we can't have that barbecue on July 4th that Joe Biden promised if people don't get vaccinated. And I bumped that up against the waves that Dr. Marty Makary made, Dr. Marty Makary from Johns Hopkins made with some op-eds in the Wall Street Journal a few weeks back. We discussed with him, where he said a couple of things. One is we're tracking to herd immunity by the end of April. Two is, here's what I would say, if you're of a certain age, get vaccinated, wait 30 days, resume normal life. That's pretty straightforward. What's your reaction to his prescription?
No, I've written multiple times that I think we are on the way towards herd immunity and that we're quite close. New studies have indicated that just a single shot of the Pfizer or the Moderna vaccines get you 80% effectiveness in interfering with disease, with the viral transmission. All you get from the second shot is going up to about 90%. And we've already reached the point where half the population has received at least one shot, and about more than a third have been completely vaccinated. So when you combine the people who have vaccine immunity with the people who have natural immunity from having had COVID and recovered from it, we are really probably very close to the 75% or so that we need to be immune to have herd immunity. So I think this whole notion of mandatory vaccines and things like vaccine passports may be a tempest in a teapot, in the sense that we may have already vaccinated enough people and had enough people recover from COVID that we're pretty close. That's what I was saying. Before you push for any mandatory vaccinations, you have to see how many people have voluntarily been vaccinated and where do we stand on that score.
And this question keeps, we keep popping it up because it seems to have been completely removed from the discussion, something else, which is treatments, therapeutics. Well, why is that monoclonal antibodies or ivermectin or other such treatments that have been not just shown a promising result, not just shown promising results like in studies, but also in real application with human beings? Why isn't that part of the discussion, especially when you're talking about younger people who are asymptomatic or mildly symptomatic? That, why, if we get I just go back to this. This is not novel, but I think it needs to be restated and revisited. Why is if you getting the flu and being down for a couple of days is not a big deal, like as long as I've been on the planet, but getting COVID and being down for a few days is a big deal? And it's such that a treatment is insufficient, a vaccine is required.
Well, that's the point is every year, somewhere between 20 to 60,000, and sometimes more, people die from the flu. So it's not, everyone says, oh, it's just the flu. But the fact is the flu can be deadly, and it is deadly year after year after year. But no one seems to be cognizant of that. Now, as best we can tell, and as you say, this is a moving target. The data is still coming in and understanding still evolving. The COVID is a bit more deadly than influenza, but it's in the same order of magnitude. It's not like Ebola where half the people who get it die. So, we've gone crazy about this. But I mean, so no one is, I don't think anyone's ignoring treatments, but I do think what has to happen is what happens normally in science. People propose treatments. They say, hey, it seems on an anecdotal level this helps or works, or here's a reason why we think it might work. Here's our hypothesis. Then you test it. So some of these things have been tested, like hydroxychloroquine. There were very good reasons to think that it might work. There were some anecdotal reports that it was working. But when larger studies were conducted, it didn't seem to be as effective as it was hoped it would be. And that's the way science is supposed to work. And that's, hopefully what's happening with some of these other treatments.
He is Dr. Joel Zinberg, Senior Fellow at the Competitive Enterprise Institute in D.C., Associate Clinical Professor of Surgery at the Mount Sinai Hospital in New York. Dr. Zinberg, thanks as always for joining us.
My pleasure.
Thank you. And he joined us on our turnkey.pro answer line.
There's only one radio show in Chicago talking about today's biggest stories and telling you what they really mean. That show is this one, Chicago's Morning Answer on AM 560, The Answer.
Did you know regular routine maintenance on your roof is as important as changing the oil in your car?